Welcome to Unit 4. This unit is on the concept of perfusion. There are several exemplars that we're going to be teaching you this time. Acute coronary syndrome, which is also an umbrella term for a myocardial infarction, which is a heart attack, and angina. Also, we're going to start off with hypertension, aortic disease, peripheral artery disease, peripheral venous disease, which is also known as chronic venous insufficiency, and we're going to talk about deep vein thrombosis. Objectives define and describe the concept of perfusion. We're going to identify risk factors for impaired perfusion, recognize symptoms that patients present with when they have a compromise in their perfusion, and also appropriate nursing and collaborative interventions to optimize our patient's perfusion. So when you think of perfusion, what do you think? So the definition of perfusion is the process of delivering blood to the tissues of the body so every cell receives the necessary oxygen and nutrients. Can we see it? Sure we can. We can see it in our patients when they are cold and clammy if they're having a myocardial infarction. We can also see cold, clammy, cool extremities if our patient, say, has been in a car wreck and they have lacerated their liver and they have lost a lot of blood. We will see that exhibited as those symptoms. So also if your patient has anemia, which is not a disease but a symptom of a disease, you would expect your patients to be pale, cool, short of breath, maybe have some chest pain, probably be hypotensive, and also have a low SpO2 because the red blood cell carries the oxygen around, and without the RBCs, then that becomes a real problem for patients. So we can feel it by taking our fingertips and testing, the temperature, those kind of things of the patient. And can we hear it? Sure, we can hear their blood pressure. We can listen for any bruits or different sounds that we hear as blood is going through a turbulent area. So here's the definition. There are 5 types of perfusion: gastrointestinal, cardiopulmonary, cerebral, peripheral, and renal. So renal perfusion, of course, is blood flow to the kidneys. The importance of the kidney does so many great things. It maintains homeostasis. It maintains fluid balance. It also makes sure that our acids and bases are in some sort of a balance. If our blood is too acidic, the kidney will dump the hydrochloric acids into our urine, and it will reabsorb bicarbonate, which is the base, to try to get our pH back to a normal level. It also maintains our electrolytes, keeps them in balance. It also produces some hormones. Produces erythropoietin, which is the hormone that is needed to make our red blood cells in the bone marrow. It also makes vitamin D and lots of other things it does. So what can impair perfusion to the kidney? Anything that is stopping good blood flow and good perfusion to the kidney. Your patient has dehydration. They don't have a lot of volume on board. If you've ever had the flu or were vomiting for another reason, your urine would become dark because the brain tells the kidneys, we don't have enough volume. We need to stop making urine. So the urine that you do make is going to be very dark and concentrated. It also filters waste products out of the blood. So urea, creatinine, and any water toxins also. And of course, it makes urine as well. Gastrointestinal perfusion, blood flow to the GI tract. Your GI tract is your stomach, your liver, your pancreas, small and large intestines, and your gallbladder. The importance of good perfusion is for good peristalsis, for your GI system, overall metabolic health. Of course, the stomach and our colon absorb nutrients. We also have mucosal lining integrity. If there is a problem with bacteria in the GI system and the stomach, some patients will develop peptic ulcer disease. They'll get an ulceration. I've seen patients who were vomiting up frank blood because they had a duodenal ulcer or some kind of ulceration in their stomach that eroded into a blood vessel. Also prevents translocation of bacteria. The GI tract is not sterile, has tons of good bacteria and tons of bad bacteria. So by maintaining peristalsis and keeping the acid levels there, bacteria just travels on down the line as it should. Impaired perfusion, again, anything that impairs our volume. Duodenal ulcers, those kind of things, losing fluid, losing acids. Improving perfusion is going to be volume. It's going to be fluid. Peripheral perfusion, as you just learned about mobility and fractures, you should have learned also about the 6 P's of perfusion, and those are paralysis, paresthesias, pain, poikilothermia, which is temperature, pulselessness, and pallor. So peripheral perfusion is highly important for oxygen delivery to all of the cells, nutrients to all of the cells, also removes carbon dioxide and lactic acid from the blood, actually regulates our temperature with the help of the hypothalamus, promotes nerve function, healing, and skin health. And again, volume is everything that's going to impair perfusion and also improve perfusion. Cerebral perfusion is blood flow to the brain and the spinal cord. The brain cannot store 2 things, oxygen and glucose. So having good cerebral perfusion is going to make sure that our brains have enough sugar to function and we get good oxygen blood flow so we don't have a negative outcome. Also, waste management, thermoregulation, again, nerve impulse transmission, and of course, cognitive function. Improving perfusion, having a good blood flow to that area, making sure that your patient has homeostasis of their fluids. And there are many, many things that can impair perfusion if your patient has had a stroke, if your patient has thrown a blood clot or some kind of embolus into the brain, typically comes from the heart. Your patient has atrial fib. As their atria are fibrillating and blood's not moving very well, blood tends to clot, and then the heart sometimes can kick a blood clot up through the carotid arteries, and it gets stuck in one of the branches there. And then anything distal to that clot is going to die. And we know that brain cells currently do not reproduce or replenish themselves. Cardiac perfusion, blood flow to the heart and lungs. Importance, gas exchange, oxygen delivery, waste management, carbon dioxide, lactic acid, those kind of things. Also regulates our blood pressure. The heart contracts and that makes us have stroke volume times blood pressure equals cardiac output. Also does a little thermoregulation as well. So if your patient has impaired central perfusion, this is reduced blood flow to vital organs. If a lot of times, if it's severe, it's associated with shock. Hypovolemic shock, of course, is your patient is hypotensive and they are tachycardic because the heart is trying to beat faster to get more blood and more oxygen out to the body, but it actually does the opposite. It reduces cardiac output, and we have less blood flow that goes out into our system. If your patient has sepsis or bacteremia, there are some endotoxins that are byproducts of bacteria. Those will damage the vessel walls, cause blood clots to form, causes an erosion, causes all kinds of problems, as well as the patients are very hypotensive, and they get lactic acid that is built up, and they get very, very sick. Anaphylactic shock, similar to sepsis in that our vessels vasodilate, they get larger, and we have the same amount of volume, but it's like a larger pipe, and so we still have reduced cardiac output and reduced central perfusion. Cardiogenic, of course, has to do with damaged heart muscles. Neurogenic most commonly is due to a spinal cord injury. Any of these things left untreated will lead to ischemia or death of the brain cells, cell injury, and then cell death. So why does it matter? This is serious because the brain needs constant supply of oxygen. Without it, patients show confusion. They can be unresponsive, and brain damage can happen very quickly. The heart needs blood to pump effectively. So if we don't have good blood flow or good volume in our vessels, then we can have heart damage or heart failure. And also, we can also have a myocardial infarction if we have things that are floating through our system and they get stuck in a coronary artery. Everything distal to that clot, that part of the heart will die. It will become akinetic, which means it's not moving, and the patient, that part of the heart will not participate in cardiac output. Common signs and symptoms here, the brain signs, confusion. If your patient has a new onset of confusion, the first thing that you should do is check their pulse ox. See if they are hypoxic, because restlessness and confusion are really early signs of hypoxia. Also, you want to get a fresh set of vitals and see if your patient is hypoxic or hypotensive. We also see dizziness, fainting, dysphagia with an S, that's difficulty speaking, and they have a decrease in their sensorium or their cognitive ability. The heart, we're going to see chest pain, shortness of breath, a weak pulse. They will be hypotensive, and they may develop an irregular heart rate. General signs: cool, clammy skin, pale, cyanosis, and extreme fatigue. In infants and children having inadequate central perfusion, we're going to see poor feeding patterns. Sometimes neonates just don't have the power to actually suckle and to control the fluid that is in their mouths. So, they have failure to thrive. They have poor weight gain. And most times, if they have a heart condition, they're going to see a dusky color either immediately after birth or shortly thereafter. With toddlers and children, we're going to see squatting and fatigue. And kids do that because if they're squatting, they are actually reducing venous return to their heart. And it also helps them manage their shortness of breath because the heart is not being bombarded with all of that fluid from the periphery. Also, we're going to see some developmental delays, failure to hit those milestones. So, tissue or local perfusion problems, in simple terms, this occurs when circulation to the areas like your legs, feet, arms, and hands are not adequate. Why it matters: we need oxygenated blood to stay healthy. When blood flow is reduced, cells don't get nutrients, cells don't get oxygen. We get those waste products built up. If you've had it in biology yet or have learned it elsewhere, when the body cannot do aerobic metabolism, it does anaerobic metabolism. So the prefix an means without. So without oxygen, the patient is going to go the anaerobic route, and the byproducts of that are going to be lactic acid. Patient's lactate levels will rise. Patient will become acidotic. That's when tissue damage can occur due to a lack of perfusion, and sometimes it can lead to, as I said, ulcers or gangrene in the patient. These are the common signs and symptoms, things that you will see sometimes early. Cold hands and feet, pale bluish or mottled skin. Mottled skin is usually sort of near the end of life. If your patient is mottling, we are way behind the 8 ball. We have missed, again, those subtle signs of a little bit of confusion or a little bit of peripheral cyanosis, or they're cool in the periphery of their bodies. So we're kind of behind the 8 ball with that. They can also get numbness or tingling. You think about a diabetic patient that doesn't have great circulation because their hyperglycemia has destroyed the vessels to carry the blood. It's destroyed the nerves, also in the periphery, and they get that numbness and tingling, which we call neuropathy. Also pain, especially with walking. This is called intermittent claudication. This is the primary symptom for patients who have peripheral artery disease. Of course, we would see slow capillary refill, anything that is more than 3 seconds, and poor wound healing because we don't have nutrients such as protein and good blood flow going to those areas, so the body can take care of its business. So we'll move right into hypertension. For this, there are 5 factors that influence blood pressure, and that's your cardiac output. So the formula, which you do not need to memorize, is cardiac output multiplied by the systemic vascular resistance, and that's how we get blood pressure. So if your patient is septic and they are super vasodilated, or if they've been stung by a bee and they're going into anaphylaxis, again, their vessels are very dilated, so that is a reduced systemic vascular resistance, so stands to reason that our blood pressure is going to drop. So your blood pressure's based on how much cardiac output you have. Normal cardiac output is 4 to 8 liters in 1 minute that your heart pumps out every minute to the body and out to the periphery. Peripheral vascular resistance. How much volume do we have circulating around in our vessels? How thick or viscosity is of our blood, and how elastic are our vessel walls? If you go back to first semester, you think about the elderly and orthostatic hypotension. This is why we have the elderly sit on the side of the bed, get their bearings, stand up slowly, because if they stand up too quickly, they have lost the elasticity of their vessel walls and their blood pressure just plummets. And then they get dizzy, and then they hit their head, and then they have to go to ICU, which is never a good day. So we've talked about this before, the mean arterial blood pressure, or your MAP. This is not new. It's been around for quite some time, but this is like the new determination of if your patient's blood pressure is adequate or not. So the formula for the MAP, which I do want you to know this, is the systolic blood pressure, which is the top number, plus 2 times the diastolic blood pressure, which is the bottom number, and you divide those by 3. So an adequate MAP is 60 to 65. 60 is like low normal, bottom of the barrel. 65 is something that we strive for in our patients who are more critically ill, because we want to be sure that they are perfusing all of the organs in their body. So the definition of hypertension is having a top number that is greater than 140 and a diastolic or a bottom number that is greater than or equal to 90. So it takes 2 different instances, or say visits to your primary care doctor's office before you are actually diagnosed with hypertension. Because there are lots of reasons why people can have high blood pressure. There's something called white coat hypertension. Some people's blood pressure just goes crazy when they go to see their provider because they're nervous about A, B, or C. We also know that people will have hypertension, temporary hypertension, if they're having pain. Also, sometimes if they have a fever, their blood pressure will be higher. Lots and lots of reasons for hypertension. So there are 2 types of hypertension. Now your book has tables in there that talk about stage 1, 2, 3, 4, 5. Do not even begin to memorize that. As nurses, we just need to know, wow, this person's blood pressure is high. The doctors can determine if it's stage 1 or stage 2 and whatever they want to do about it. So, but primary hypertension is something that I have. I have genetically on both sides of my family, very young, developed high blood pressure. So I've had high blood pressure since I was 33. So there was no cause. I didn't have diabetes. I didn't have like a tumor on my adrenal gland. I didn't have a really highly sensitive sympathetic nervous system. None of those things. I just got bad genes and I had high blood pressure. So primary hypertension, no single identifiable cause. It is the most common, 90 to 95% of us. Cause gradually develops over time due to genetics, poor lifestyle, poor diet, too much alcohol, too much salt. I mean, you name it. Those are all the things that contribute to hypertension. Usually develops over years. More common in adults, especially middle-aged and older. Secondary hypertension is, okay, this is due to something that I know. If your patient may have renal artery stenosis, that is an increased pressure in your renal artery, which backs up in your system and causes you to have hypertension. Also, people who have diabetes most typically will have hypertension at some point because there's damage to the inside of their vessels and it causes the intima to narrow, and it's trying to push blood through something that is more narrow. People who have high cholesterol, typically also for the same reason, they have all the plaques and the narrowing in their vessels, and it causes that blood to have to be pushed through a very narrow space, which causes turbulence. But this is something secondary we can say, okay, this is the reason you have hypertension because of A, B, or C. Here's some other common contributing factors. Some people just have a really overzealous sympathetic nervous system and maybe too much epinephrine, too much norepinephrine that clamps down and causes them to have high blood pressure. As the other things I said, diabetes, eating too much salt, drinking too much alcohol, or an increased basal metabolic index, which is a very nice way of saying that they are overweight and obese. Secondary hypertension, here's some things here that can cause people to have high blood pressure. Pregnancy-induced hypertension or hypoxemia. Hypoxemia, that's not the word. It's PIH. Some pregnant women will have high blood pressure while they're pregnant, and it goes away as soon as they deliver. People have sleep apnea because depending on how bad it is, you are not breathing, you're having apnea throughout the night. That causes cardiac disease, which also causes people to have high blood pressure. If you remember back to endocrine, patients who have hyperthyroidism, they also tend to run fast, they run hot, and their blood pressures will be high. There are some cultural differences for hypertension. Blacks or African Americans have a higher rate of hypertension. They often develop it earlier than Caucasians or other ethnicities. It is more likely to be severe. They are also more likely to develop diabetes and have renal problems related to their hypertension. They have many more complications. Um, and some blacks, just from their ethnicity, have a salt sensitivity that is much higher than other ethnicities, which they attribute to their problems with hypertension. South Asian populations also have a higher risk of heart disease and also develop hypertension at lower body weights. You know, they may not be overweight at all, but based on their genetics and their genealogy, they can also have high blood pressure. Hispanic, Latino populations, risks vary with them. Some groups have higher rates of diabetes, which again increases their hypertensive risk. Cultural dietary patterns. Some of their traditional diets contribute to higher blood pressure, really high sodium intake. Those who eat salted meats, like soy sauce, pickled foods, processed foods, all of these things can also come from poverty, particularly the blacks and the people who live in the South who live in poverty. They tend to not eat very well because they do not have the income to do so. They may live in what's called a food desert. They may have food insecurity. A food desert basically means that there are no, large chain grocery stores around, so they don't have good opportunities to buy fruits and vegetables, or like the elderly, they don't have the income. After they buy their meds and pay their Medicare and all that, they don't have money to buy fresh fruits and vegetables. So they also, um, that is a problem for them. Some cultures also eat foods high in carbohydrates or eat fried or high-fat foods. A lot of cultures, just like the blacks and people in the South, also people over in Europe and Asia, they just don't believe in Western medicine. They don't trust it. A lot of them maybe have had bad experiences in the past with the healthcare system, and they're just really not willing to go back and put themselves through that again. Particularly blacks and living in the South, they have a tendency to believe that it is fate or it is God's will that they have diabetes, or it's God's will that they have high blood pressure, and they do not seek any medical treatment for that. Also, again, poverty. A lot of people in the South don't have insurance. Heck, a lot of people in the North don't have insurance. So, they're working jobs that do not provide insurance for them. They may make just about a little bit too much money to be able to, get assistance from the state, with Medicaid or food stamps or SNAP benefits, any of those things. Also, a lot of times it's a language barrier. They're not quite understanding, what their doctor is saying. If their doctor is foreign, they're really not always going to be able to understand. And that's why, as nurses, we make rounds with our doctors so we can translate sometimes for them. There's lots of times I would walk back in the room and say, did you get any of that? Did you understand what he or she was saying? And so we also do that a lot as part of nursing practice. Also, particularly in Appalachia, there are a lot of herbs, old wives' tales, a lot of things like that, or they take a lot of vitamins, they take a lot of herbs and things that actually interfere in a big way with their prescription medicines. So I had a patient one time, he came in with a blood clot and he was on Coumadin, but his wife brought in his home meds, which were mostly like from GNC, things that are not FDA approved. There were like 50 bottles of things, and 50% of them actually counteracted his Coumadin. So he was taking the Coumadin, but it wasn't doing him any good, and he developed a blood clot anyway. So we have to ask a lot of good, direct questions about what our patients are taking at home. Other things, social and environmental factors. As I said, all of these: lower access to healthy food, limited access to healthcare, lower income or education levels, living in high stress environments. All of these things are linked to patients developing hypertension. Why this matters, we need to ask, as I said, the right questions. We need to find out, why sometimes you have a patient who they've been prescribed furosemide, Lasix, because they have congestive heart failure. And if we don't do a good job teaching them how to take this med, I've had patients tell me, oh, I can't take that Lasix. I'm allergic to that. It makes me pee. Well, that's an epic fail on behalf of the nurse who did the discharge teaching. We have to be able to teach our patients what are common side effects, what are things that you should expect. Don't take your diuretic at bedtime because it is going to keep you up all night and you're not going to sleep well. We should all be practicing culturally sensitive care. If we have a patient who is a different culture, as you guys are studying and doing your projects right now, there are a lot of cultures that are very patriarchal, which means that the husband is going to do all the talking for the wife. The father is going to do all the talking for the daughter, for the wife, because that is how their society is. You don't make good contact. You don't speak to the patient if she's a female, because that is not their structure. Other things, making eye contact with some cultures. They find that to be very rude, and they distrust you almost immediately. Also, I know that you've learned that we need interpreters sometimes for things, and we never ask the family members to interpret because we don't know what the family member is telling the patient because we don't speak that language either. So, and sometimes they will not tell their family members the truth. So we have to find out why they're not taking their meds. Is it financial? Then we get caseworkers on board to help. Maybe they need help applying for Medicaid. Maybe they need somebody to speak on their behalf to a big drug pharma company that we could get them, reduce prices or get them free meds. That happens a lot. So when we talk about hypertension, we also talk about target organs that are affected by hypertension, and they're all listed here. So symptoms related to target organ damage of the heart from CAD or heart failure, these are their symptoms. They may present with chest pain, which is angina or angina, whichever you prefer, shortness of breath, swelling in the legs, fatigue is very common, and having an irregular heart rate heartbeat, such as atrial fibrillation. Stroke or TIA that's organ damage to the brain. We know sudden weakness, especially to one side of the body, slurred speech, headache, dizziness, vision problems, confusion. And I'm sure you maybe have learned or seen it in the hospital about FAST. So the FAST is the F stands for facial drooping. The A stands for arm, difficulty moving their arms. S is slurred speech. And T is time. They need to get to the hospital early so they can get treatment. So hopefully they can't really stop the stroke from happening, but they can definitely, with good treatment, lessen the complications. Chronic kidney disease is also a real problem from hypertension. We see that probably most commonly, as common as heart damage. So kidneys aren't working well. Their job is to get rid of excess fluid that they have. So if the patient presents swelling in their feet and their ankles, sometimes that's very telling that their kidneys are the issue. Of course, decreased urine output in the late stages of chronic kidney disease. Fatigue, and that is related to the swelling in the legs, but it's also related to not having enough red blood cells, because again, the kidneys produce erythropoietin, which produces our red blood cells in the bone marrow. So all of your kidney disease patients will be anemic, and it is 100% related to the erythropoietin. Also, they develop some nausea with advanced kidney failure. Also can get hypertensive retinopathy with eyes, blurry vision, vision loss, seeing spots, and your blood vessels. Peripheral artery disease, they will get the intermittent claudication, which is leg pain while walking. And if it's arterial, then they're going to have weaker pulses because the arterial side, of course, is the pulses. So. Diagnostic studies for hypertension. Everybody gets a BMP, basic metabolic panel. This are all your electrolytes as well as your BUN and creatinine. Again, your creatinine is your gold standard for kidney function. Your BUN can be related for many, many different reasons that have nothing to do with your kidney. So we're going to figure out what our electrolytes are. Also, fasting blood glucose or a hemoglobin A1C. This is screening for diabetes. The A1C is the average blood sugar for the last 120 days. It is called glycosylated hemoglobin because the sugar molecule attaches to the hemoglobin, and your hemoglobin and your red blood cells live for about 120 days. So this is a 3-month, 4-month average of your blood sugar over that time period. And also doing a lipid panel, which is a fasting blood test in the morning after admission, checking cholesterol, checking triglycerides. Other things, electrocardiograms. Many of you working as a tech, of course, may have done this in the hospital. Looking for left ventricular hypertrophy. The left ventricle is the most powerful chamber in the heart. It is the one that receives the oxygenated blood from the pulmonary vein into the left atria, through the mitral valve, into the left ventricle, and then pushes that blood out of the aortic valve. So if you have problems there, that the left ventricle isn't working well, hypertrophy means that wall of that chamber is larger, and then it becomes less elastic. So blood tends to pool in that area, and then it can't propel that out which is actually called afterload. Afterload is the pressure that it takes for the left ventricle to exert that blood through the aortic valve. Also, patients who have a prior heart attack, that is permanent damage to the myocardium, so doesn't participate in cardiac output, and also arrhythmias. We're looking for anything that is not normal, like something that is not normal sinus rhythm, sinus brady, sinus tach. We're looking for atrial fib, atrial flutter, V-tach, and V-fib, which those last two are lethal rhythms. Some patients need an echocardiogram, which is an ultrasound of your heart. They can look at the chambers of the heart. They can look at all of the valves and make sure that they are not stenotic, which means they're hardened and they're not closing all the way, or they're not floppy and regurgitating, and then the blood is traveling willy-nilly back and forth between the atria and the ventricle, which also causes hypertrophy. They can also see if the patient has like endocarditis or vegetation that is growing on the valves. We most commonly see that patients who are IV drug users, they tend to develop infective endocarditis as a result of that. But the echocardiogram can also measure pressures, and it can determine what your not your cardiac output, but your ejection fraction is how much blood is going out through the aortic valve. And a normal ejection fraction, which we hear it called EF, is about 60 to 65%. So patients who have heart failure or who have had a heart attack, they do echoes on them, and if it's 40% or less, they have to go home with an ACE inhibitor, which will assist with that and help to some degree their ejection fraction to improve. Also, urinalysis is really important for hypertension. You should not have protein in your urine unless you have pretty significant kidney disease or you are really good and pregnant and have hypertension. The proteins should not be falling through the glomeruli and leaking into your urine. So we shouldn't see any of that. But that is also telling of hypertension and early kidney damage. Other things, they might do a thyroid function test if they think that you are hypo or hyperthyroid. Renal ultrasound if they're looking for renal artery stenosis. Also aldosterone or renin levels. Also if you might do a sleep study if you have sleep apnea to determine hypertension. So we have to make sure that not only we as nurses, but our patient care techs and our ancillary people are also using a cuff that is the right size. If we're using one that's too small, which is the most common error, we're going to get a falsely high blood pressure. If it is too large, we're going to get a falsely low blood pressure reading. And it could lead to unnecessary treatment, unnecessary medications. It can also delay treatment for some patients. Benefits of lowering blood pressure are obvious. Reduce the risk of heart attack, prevent heart failure, decrease the strain on your heart, lower your risk of stroke, and also reduce your risk of vascular dementia. And even a modest reduction, 10 millimeters of mercury, lowering your systolic, significantly reduces your cardiovascular risk. Benefits to your kidneys could slow progression of kidney disease or prevent kidney disease. Blood vessels prevent damage to arteries, which could prevent your risk of blood clots, prevent your risk of a plaque breaking off and causing a stroke, or a blood clot going to your lung and causing a pulmonary emboli, and reduces the risk of peripheral artery disease. So, what can we do? Teach our patients, put the salt shaker down, reduce their sodium intake, follow a heart-healthy diet, and this DASH diet, I want you to be aware of the kind of things that we should be teaching our patients about the DASH diet, and they're all listed here. Low-fat dairy, nuts and legumes, which are beans, low fat, low sugar, eating whole grains, and several servings of fruits and vegetables a day. Maintaining a healthy weight, we should be helping them understand how being overweight even a little bit puts a lot of pressure on all of our major organs. And regular physical activity. NCLEX wants you to encourage 150 minutes a week of moderate exercise if tolerated, 30 minutes most days, walking, cycling, swimming, whatever your drug of choice is. Limiting alcohol, men no more than 2 drinks a day. This is liquor. Women no more than 1 drink a day, because too much alcohol raises your blood pressure. Also, of course, quit smoking, manage your stress. Wouldn't we all like to know how to do that? Get adequate sleep, 7 to 9 hours, if that's good enough for you. Chronic stress can also contribute to elevated blood pressure. So we all need to learn how to manage our stress better. So pharmacology stuff, that's going to be more towards the end of the unit. But the primary action of these drugs are to reduce your systemic vascular resistance. We do that with vasodilators, vasodilate those vessels, and also reducing the volume of circulating blood. We call this reducing preload. The primary drug of choice for that are diuretics. They're going to remove a lot of the extra water, so your heart doesn't have to beat all of that volume around and work too hard. Also, vasodilators will keep the blood in your periphery, so it's not all returning back to the heart. So we will go over different diuretics, adrenergic inhibitors, which are beta blockers, vasodilators, the ACEs and the ARBs, and calcium channel blockers. Nursing management, we have to measure the blood pressure correctly. Not just going nuts because we have one really high reading or one really low reading. We need to trend the readings. We need to go back and look at what their blood pressure has been in the last 24 hours. Also, we need to figure out what could possibly be causing this blood pressure to be high. Are they really anxious? Are they really nervous? Are they in pain? Do they have a fever? Lots and lots of reasons why people's blood pressure will be high. So also looking for all of these, assessing for target organ damage. So for the kidney, of course, we're going to be looking at B1 and creatinine. For the heart, we're going to be looking at troponins, CPK, CPK-MB, all those things that I will go over on another day. Looking for changes in their vision and any neurologic changes. So, as a review, we're going to teach our patients to comply with their medications, hopefully. We're going to teach them about a low-fat, low cholesterol, low-sodium diet. We're going to encourage them to exercise to the best of their ability. Encourage them to stop smoking or reduce smoking, stop drinking or reducing their alcohol intake, ways to manage their stress, and we're going to take a good look at their family history. Health promotion, all very individual for our patients. Encouraging them to get their blood pressure taken. Any pharmacy, grocery store anymore has blood pressure machines that you could get. Also, you can pick up a blood pressure, an automatic machine anywhere. Again, grocery stores, pharmacies, anywhere. Encourage them to do screening programs. Encourage them to have their cholesterol checked when there are health fairs where it is free or it is a reduced price. Also, all other things, getting an EKG, having a colonoscopy, all the things that we should be teaching our patients, and we should be doing it too. There is, these are the last two slides. Hypertensive crisis is somebody who is hospitalized, blood pressure greater than 180 or higher, or greater than 120 or higher. Of course, this is stroke level, but fun fact, many people feel perfectly fine when their blood pressure is this high. And that is why hypertension is called the silent killer, because nobody realizes that their blood pressure is that high. They just might feel tired, or they might feel stressed or something, and it's actually manifesting in that way for their high blood pressure. Usually it's progressive, usually managed outpatient, unless it is, super high like this. Can be treated with oral medications. Definitely needs follow-up within the next 24 hours. This is hypertensive emergency, and I misspoke. These are the people that must go into the hospital and be on the cardiac monitor, looking for arrhythmias. We have to bring their blood pressure down very slowly. You do not want to bring it down very fast. They have even higher than 180 to 120 with their blood pressure, with end organ damage problems, chest pain, dizziness, stroke symptoms, kidney problems, all of that. They need IV antihypertensive medications. What we normally use for this is a beta blocker. There's also a medication called Nipride, which is nitroglycerin, and it is an IV form. Sometimes they will put somebody on this drip for 24 hours to get their blood pressure back to normal. Takes a little bit of time with all of these meds to bring it down, and we don't want to go too fast. Blood pressure and blood sugars must be taken down very slowly. But these are some of the symptoms that you might see if your patient comes in with a hypertensive emergency. So that's that, and you should have your slides tomorrow. I had them printed on Thursday before I left, so I will see you soon.